Dear colleagues, I would like to open the session titled Comorbidities in Cardiology, a Unit of Iceberg. My co-chair, Dr. Nigar Babazade from Azerbaijan, and also board member of IYAC. We have 4 speakers, and let me first introduce one of my best friends and president of World Heart Failure Society, Dr. Babak Sharif Kashani, for his time. Babak, please.
Hello, I'm Dr. Babak Sharif Kashani, and I'm a heart failure cardiologist from Masih Daneshvari Hospital, Tehran. And today I'm going to be talking about heart failure and diabetes. We know that diabetes does affect the heart in different ways. We have a scheme here that shows that diabetes can involve the heart through the autonomic system, also through inflammation causing hypertension, fibrosis, diastolic or systolic dysfunction, and leading at the end to diabetic heart failure. This is a syndrome that could be caused by ischemia, and you can see that there are 3 mechanisms to induce ischemia, that diabetes does use all 3 mechanisms. We have the atherosclerotic disease that is more common in diabetic patients than in other groups. Also, we have the vasospastic disease, as well as the microcirculation, that when microcirculation involvement is seen in diabetic patients, we might even have heart failure without having the common symptoms of ischemic disease. So in this regard, diabetes is one of those diseases that could involve the heart through many different pathways. We know that the prevalence of heart failure is higher in patients who have diabetes mellitus. 1% increase in the glycosated hemoglobin could cause an 8% increase in heart failure, which is a very large number. Even if they are not diagnosed as diabetic, they might have cardiovascular disease before being diagnosed. And in those patients who do not have diabetes but have insulin resistance, we do see a higher increased number of patients with heart failure, suggesting that insulin resistance could be a cause of heart failure in these patients. In a study by Hofner, the 7-year risk of myocardial infarction is equal in patients who have diabetes mellitus and on those who have prior myocardial infarction. So actually diabetes is not the risk factor, but a CV disease risk equivalent. And this is very important. We're not facing a kind of risk factor. It is actually atherosclerotic and non-atherosclerotic disease. And patients with diabetes are just as in danger as those who have had a previous myocardial infarction. Knowing all these points, most patients with diabetes or with multiple risk factors don't reach their treatment goals. In this study that was published in 2010, nearly half of the patients didn't meet the targets for glycemic, blood pressure, or cholesterol control. And only 14% of them had the 3 targets in these measures. So we were not treating them as well as we should. Looking at the medications that we have for anti-diabetic treatments, you could see that it started from human insulin, the sulfonylureas, and then metformin. But now in the recent years, we have had a lot of other medications added to this list of therapies. And if you look at this slide, you could see many of these medications. I'm not going to go through this slide, but all these medications should be considered when we are trying to treat these patients with respect to their effect on the cardiovascular system. Some of them could increase symptoms of heart failure. Some of them could prevent myocardial involvements, but in talking about heart failure, we usually look at the SGLT2 inhibitors, which I'll be talking about later. These are a few studies about anti-diabetic medications in heart failure and heart disease, not only heart failure. And during these years, we have been trying to see if, first of all, these medications are not non-inferior to not treating patients, and then trying to point out which of these medications can cause a better prognosis for patients with diabetes. And recently, the last studies that we see in the year 2020 have been published. They are not, some of them are included in my slides, but interestingly, we see that these medications, especially the SGLT2s, are showing great benefits for patients with heart failure in diabetics and also in non-diabetics. This is a slide showing the effects of different studies on medications in heart failure patients. And although most medications are nearly in the midline, but SGLT2s are showing quite a favorable effect for heart failure. And this is the point that I'm trying to get to, that talking about cardiovascular disease and talking about the effects on atherosclerosis is different from talking about heart failure. Different classes of these medications. We have the DPP4s, and these medications, including linagliptin and sitagliptin, that we see in many medications used for diabetes these days, do not increase the events of acute atherosclerotic events, but because some of them could cause a worsening of heart failure, they are not used in patients who have heart failure. The GLP-1 receptor agonists also have had a very good effect on acute coronary events, but still none of them have shown to reduce the risk of hospitalizations for heart failure in patients with diabetes. So if we are going to treat these patients for heart failure alone, perhaps these are not the first choice that we should have. But on the other hand, the SGLT2 inhibitors, including dapagliflozin, empagliflozin, and other medications, have shown the reduction of MACE, the reduction in cardiovascular mortality, a reduction in all-cause mortality, and most importantly, positive effects on hospitalization and also mortality in patients with heart failure. So looking at these kind of medications, these group of medications are the ones that we want to use in patients with heart failure. The EMPA-REG and the CANVAS trials both showed that these are superior when compared with not treating the patients with these medications. There were slight differences. For example, empagliflozin was a little bit better in Asian subjects, and there were some different kinds of complications. For example, a slight increase in lower extremity amputation was seen with canagliflozin, but altogether, the SGLT2s had a very good profile when they were used in patients with heart failure. Having said all of these, regarding the morbidity and the mortality rates of diabetes mellitus and chronic heart failure, which are very high, and the impact of diabetes on heart failure, when treating these diseases, we have to have a teamwork to use those medications that can cause a benefit on the prognosis of these diseases. So SGLT2s should be introduced to the group of medications used for these patients. And we should also be aware of the shortcomings and the complications that these medications can cause, but altogether they are medications that have changed the way that we look at diabetes mellitus in heart failure. Interestingly, these group of medications, the SGLT2 inhibitors, have been effective also in patients with heart failure who are non-diabetic. And because of the time that I've got, I think this is all that I could say. Thank you for your time. And if there's any question, I'll be listening for them. Thank you.
Dear Babak, I would like to thank you again for your nice presentation. Recent developments support a more protective role in ensuring optimal glycemic and vascular protection using appropriate and new anti-hyperglycemic agent too. So may I ask you, should the cardiologist be a key position not only the optimized care of patients and management more than before?
Well, that's one of the most important facts that we have to address. Patients, diabetic patients, and heart failure patients, which are the field of my interest right now, are really high-risk patients. And using those medications that can prevent death is very important. I think that we not only should know the medications that are being used, because most of us don't really prescribe these medications, but at least if we are treating heart failure patients, we should be very well familiar with the SGLT2s and know what are the complications, when to give them, and when should we consider stopping them. These are the points that a cardiologist should really know. And I think we're going to get to the era of cardiometabolic disease. And one of the most important things that in the near future we'll see is treating these kind of patients.
Thank you. Nigar, have you any comments or any question?
No. Hello. First, hello. No, thank you, Babak Sharif, for your comprehensive speech. No, Mehdi Zoghi, I don't have any question.
Thank you.
Introduce the second speaker.
Yes, I would like to introduce our next speaker. She is Emna Allouche, and her speech will be about iron deficiency anemia in heart failure. Please, Emna.
Hello, everybody. I'm so glad to be there with you. I'm Dr. Emna Allouche, and I am from Tunisia. We'll talk about iron deficiency and heart failure. As you know, heart failure management is very challenging, and beyond all pharmacological treatment and device treatment, we have to correct and treat all patients' comorbidities such as iron deficiency, which is one of the most prevalent comorbidities in heart failure and one of the most easy to treat. Iron deficiency is very prevalent in heart failure patients, and it's found about almost 50% of heart failure patients. Iron is very important. It acts as a catalyst for important biochemical reactions. It is a component of hemoglobin and myoglobin. It plays a key role in erythropoiesis, and it's a key component of mitochondria. Iron cycle is complex, and the daily average intake of iron is about 10 to 20 milligrams. 1 to 2 milligrams are absorbed in the duodenum. There is no pathway for iron excretion. However, we lose daily 1 to 2 milligrams through skin desquamation and bleeding. Iron metabolism is very complex, and it's regulated via hepcidin, which is a peptide secreted by the liver. Mechanisms leading to iron deficiency are multiple and complex, associating negative systemic iron balance and iron sequestration from chronic inflammation. This negative balance leads to a reduced iron stores, and inflammation via hepcidin leads to a reduced iron mobilization. In this recent analysis, iron deficiency seems to be a combination of reduced iron uptake, an impaired iron storage, and iron loss. Female sex was an independent predictor of iron deficiency. Facing this issue, European Society of Cardiology strongly recommend to look for iron deficiency in every patient with heart failure. To do this, we have to forget about serum iron, and we have to use ferritin and transferrin saturation. These two parameters define two types of iron deficiency. Absolute iron deficiency, which is in which ferritin is under 100 and transferrin saturation under 20%. And functional iron deficiency, in which ferritin is between 100 and 299 and transferrin saturation is under 20%. Iron deficiency has several consequences. It causes anemia, of course, and structural cardiac abnormalities. In fact, iron deficiency impairs contractility of human cardiomyocytes through decreased mitochondrial function. It also impacts badly the response to CRT therapy and left ventricular remodeling after cardiac resynchronization therapy. Iron deficiency is the cause of an impairment of exercise capacity. It is also associated with a lower quality of life in heart failure patients. Iron deficiency is a negative prognostic factor. It is stronger than anemia, and in heart failure patients, mortality increases when iron deficiency is present. So in a patient with both heart failure and iron deficiency, he will likely suffer from 13% reduced exercise capacity, and he has his quality of life reduced by 19%, and he has an increased risk of 42% to die compared to patients without iron deficiency. So we have to treat iron deficiency, but should we use oral or IV iron? We will try to find an evidence-based answer with randomized clinical trials. Iron HF study, a randomized trial, compared the effect of IV iron versus oral iron in heart failure patients, and it concluded that IV iron seems to be superior in improving functional capacity of heart failure patients. Then iron out, the only study with oral iron in heart failure patients with iron deficiency, and its results do not support the use of oral iron supplementation in patients with heart failure. So oral iron is not effective and in this population and should not be used. What about intravenous iron? Ferric HF study concluded that intravenous iron sucrose improved exercise capacity and symptoms in patients with chronic heart failure. AV carboxymaltose was firstly tested in FER HF, and it was shown that ferric carboxymaltose improved symptoms and exercise capacity in heart failure patients. Those results were then confirmed by in Confirm HF study, and ferric carboxymaltose resulted in sustainable improvement in functional capacity, symptoms, and quality of life. It is also associated with the risk reduction of hospitalization. Ferric carboxymaltose also in effect HF improved iron stores and had a favorable effect on peak VO2. For outcomes, meta-analyses support that ferric carboxymaltose use is associated with reduced cardiovascular death, reduced heart failure hospitalization, and cardiovascular hospitalization. To confirm this data, There are several ongoing morbidity and mortality studies with IV iron. So to overcome 1000 milligram of iron deficit in a heart failure patient, the choice of the method seems to be easy to choose. And finally, European and American guidelines recommend the use of IV iron in symptomatic heart failure patients with iron deficiency to improve functional status and quality of life. And a correction algorithm was proposed with two phases, a correction phase and a maintenance phase. As a conclusion, it is proven that iron deficiency is prevalent clinically and prognostically important irrespective of anemia. And the correction of iron deficiency with IV iron improves symptoms, quality of life, and exercise capacity. So that current guidelines recommend screening of iron status in all newly diagnosed patients with systolic heart failure and consideration of IV iron in symptomatic patients and iron deficiency. Studies have been initiated to evaluate the effect of IV iron on morbidity and mortality endpoints. After that, I think that Popeye will switch for IV iron, and thank you for your attention.
Thank you, dear Emna, for your amazing speech. And I think that being aware of iron deficiency avoids challenges in heart failure management. And you talked us about the essential points of iron deficiency. Thank you. Dear Mehdi, Zoghi, do you have any addition or question?
Thank you, Emna. May I ask you, is there any difference between prevalence, outcomes, and prognosis in heart failure with preserved ejection fraction versus low ejection fraction? Are there any data? Would you please open your voice?
Okay. Thank you for this invitation. I'm so glad to be with you, even virtually. For heart failure with preserved ejection fraction, there are ongoing studies to prove that iron supplementation is favorable for the prognosis.
Okay, thank you.
Thank you.
If there is not any question, we should move for the next speakers. Channelopathies are a heterogeneous group of disorders caused by either genetic or occurred factors. Will be presented by Dr. Silvia Castelletti from Italy. I guess you will more focus on cardiac arrhythmia and sudden death. Please, Silvia.
Dear colleagues, dear chairman, good afternoon. First of all, thank you for inviting me. The topic is channelopathies and comorbidities. However, although channelopathies are just a few, comorbidities are so many that 10 minutes would have not been enough to talk about. This is why I have decided to focus on two main aspects: the importance of the genetic substrate in common diseases and the main troublesome aspect for comorbidities managing in patients with channelopathy. Let's start from the first point. Main channelopathies are long QT syndrome, Brugada syndrome, and CPVT. What do they have in common? They are genetic disorders characterized by normal echocardiogram. Sometimes also the basal ECG may be normal. They may cause sudden cardiac death, and their instant triggers may include drugs, low potassium levels, and physical activity. You all know that a channelopathy is a genetic disorder where the patient carries a mutation on a gene encoded for an ion channel, and this increases the risk of life-threatening arrhythmias. So this is a very special population because they at baseline have an increased risk of sudden cardiac death. You probably do not know that all of us carry common genetic variants. However, these genetic variants may have a different effect on a patient with a channelopathy. Indeed, these are called modifier genes, and these are relatively common genetic variants capable of modifying with small quantitative effect the level of expression of a disease-causing gene. We have demonstrated this for the first time 15 years ago, when we observed that a 40-year-old woman who had a cardiac arrest had a prolonged QT and was carrying a mutation on an SQT2 gene and also a very common variant, the K897T polymorphism, that is present in the 30% of the general population. We noticed that all the family members were carrying either the mutation, either the common variant, and none of them had experienced any allergic events, and none of them had a prolonged QT interval. So we concluded that a very common KCNH2 polymorphism may modify the clinical expression of a latent LQT2 mutation. This has a very important implication because we postulated that a similar genetic mechanism may contribute to the risk of sudden death in more prevalent cardiac diseases such as myocardial infarction or heart failure, and may facilitate its drug-induced the point. We have indeed demonstrated that the same polymorphism causing a worse phenotype in a long QT patient is able to increase the risk of life-threatening arrhythmia following acute myocardial infarction also in the general population. We have moved on and we have found several polymorphisms that may increase the risk of life-threatening arrhythmias, but also that may protect from the risk of life-threatening arrhythmias. This means that if you have an arrhythmogenic substrate due either to a myocardial infarction or a failure, either to a disease-causing mutation, what really makes the difference in the outcome between life and death is the presence of a predominant protective polymorphism or a predominantly detrimental polymorphism. This concept has been strengthened by several observations of the major role of the presence of genetic factors predisposing to the onset of life-threatening arrhythmia, also ischemia mediated. Based on this observation, now there are two big studies ongoing that are exploring the role of genetic variants in developing ventricular fibrillation during myocardial infarction. One is the ACNET study, and the other one is run by our group and is called Predestination. Both of them are comparing patients with the first myocardial infarction not complicated by ventricular fibrillation with patients with first myocardial infarction and ventricular fibrillation. Now, let's move from patients with coronary artery disease to patients that do not have coronary artery disease. Let's move to the normal population that may need a drug that can prolong the QT. Some patients may display a QT prolongation. These patients are called a patient with acquired long QT syndrome because they do not have the syndrome, but they show a QTc prolongation if they are on certain medication. So we have demonstrated that a third of these so-called acquired long QT syndrome patients do carry a long QT syndrome mutation, those on KCNH2 being more common. From this study, we have also identified 3 predictors of the probability of being mutation carriers in an acquired longevity patient. And we have shown that those patients carry 2 or 3 of these predictors are more likely to carry a longevity mutation. So be careful when you give drugs that are able to prolong the QT. Be careful to give predisposing predictors of the probability of being a mutation carrier. Let's move to the main troublesome aspects for comorbidity managing. So we know that limiting triggers may include drugs, low potassium levels, and physical activity. Drugs. In long-QT syndrome, there are several drugs that must be avoided because they are able to prolong the QTc, like antibiotics, but also some antitumoral drugs. So what to do for those patients with a long-QT syndrome that need one of these drugs for a long period of time? First of all, think to those patients that are in a hospital unit, and you may monitor them and pay attention to some ECG signs that are predicting for toxicity points. For example, the QTc interval per se. The more prolonged it is, the more is the risk. The QTu prolongation and distortion after a pause, and of course, the behavior after macroscopic way after that you can see here. Of course, all long-QT patients must be on beta blocker therapy. And bear in mind that not all beta blockers are equal. Indeed, the most effective beta blockers in long-QT syndrome are nadolol and propranolol. For those patients to which you need to give drugs that may prolongate the QT for a long period of time, you may consider also to increase the protection from life-threatening arrhythmias with less cardiac sympathetic innervation. Also, we may consider the use of remote monitoring systems. We have demonstrated a few years ago that some devices are able to identify a prolonged QT interval and probably also subjects at risk for transient QT syndrome. Also, patients with Babazade syndrome have to avoid drugs that may elucidate a spontaneous pattern. However, sometimes these drugs cannot be avoided. What we do in our practice is to implant a loop recorder to monitor these patients. Low potassium levels are very important in inducing arrhythmic events in patients with a channelopathy, but also in patients without a channelopathy. Indeed, from our predestination study, we have demonstrated that patients with acute myocardial infarction that have ventricular fibrillation have a significant lower potassium level compared to those that have not ventricular fibrillation at presentation. So be very careful with a non-QT patient or more in general a patient with a channelopathy. Monitor the potassium level, monitor the renal function, and be very careful for those patients that have also a comorbidity, a renal failure that needs dialysis, as there is an iron imbalance during the dialysis that may increase the risk of life-threatening arrhythmia. And it is also well known and well demonstrated from the high risk of sudden death in the interdialysis period, also in patients that do not have a channelopathy. Why I'm also stressing on physical activity? Because we know that patients with the channelopathy should avoid competitive sport. Sometimes this means that these patients are scared to exercise at all, and you know that exercise instead is very important for the control of the risk factor of ischemic cardiovascular disease. This is why we should promote not competitive physical activity in these patients. Finally, speaking of comorbidities in COVID-19 times, please note that there is a working hypothesis that inflammatory markers before the inflammatory status of the patient may be associated with lung QT prolongation due to a direct effect of inflammatory cytokine, mainly interleukin-6, on cardiac ion channel function. So the arrhythmias in this patient may be not related per se to the administration of the drug, but may be independent from that. Thank you for your attention.
Thank you very much for your excellent presentation, Silvia. There is one question from our audience to you. How we do manage patients with long QT syndrome, asymptomatic patients that need beta blockers?
I'm sorry, I'm not sure. You asked me what do we do with patients that need beta blockers?
Yes.
We give beta blockers to long QT patients. You cannot give them because beta blockers are very effective in reducing the risk of life-threatening arrhythmias. They reduce the risk from the 10% to the 1%. The problem is, of course, with the asthmatic patients because those patients cannot take beta blockers. They may have some problems. So in these patients, we use a lower dose of beta blockers, but we perform also left cardiac denervation.
Okay, thank you. Nigar?
Yes.
Is there any more question from audience or have any comments from you?
I have a question to Silvia about generally, is the screening practicable in channelopathies?
Yes, so the genetic screening is positive in the 80% of patients that have the syndrome. So also according to the guidelines, the genetic screening is in class 1A in patients with long QT syndromes. And if you find the mutation, it's mandatory to perform the genetic screening also in the family members because there are 20% of family members that may display a normal QT interval and still carrying the mutation. And those patients have still the 10% of risk of sudden cardiac death higher compared to patients without the mutation and the normal QTc.
Thank you.
Thanks to you.
And our next speaker is Elif Uzay from Turkey, and she will talking about genetics and drug response in cardiovascular disease. Please, Elif.
Hi, welcome everybody. I am Dr. Elif Uzay, and I am medical geneticist. Today, I'm going to speak about genetic and drug response in cardiovascular diseases. So, over the past decade, there has been increased recognition of genetic causes for many types of cardiovascular disease. Previously, it was difficult to make genetic diagnosis because testing was expensive and rarely available. But nowadays, with the advancement of massively parallel DNA sequencing technology, we have wider availability of gene panels and exome sequencing in cardiovascular genetics. Many cardiology guidelines now incorporate genetic data in recommendations for diagnosis and personalized clinical management. For the clinical cardiologists, need to understand at least basic principles of cardiovascular genetics to recognize which patients may have an underlying genetic condition, and refer patients for genetic testing when appropriate. Today, I'm going to focus on three main categories of cardiovascular disease. They are aortopathies, cardiomyopathies, and arrhythmias. Now, I will speak about some basic genetic definitions. Firstly, I will speak about single nucleotide polymorphisms, frequently called they are SNPs. Single nucleotide polymorphisms, they are the variations at specific locations in the DNA nucleotide sequence with a population frequency at least 1%. Each of us has about 4 or 5 million SNPs. They are non-pathogenic variants and mostly found in non-coding region of the DNA. And also, we are still continue to discover SNPs due to Mendelian randomization studies and genome-wide association studies. However, some of them can be in regulatory regions of DNA or within a gene, may predict risks for disease or different responses to the medications and environmental factors. And if we have the pathogenic variants, it can be due to single nucleotide change, due to deletion, or due to insertion. Also, they are transmitted to the next generation in autosomal dominant or autosomal recessive trait, or they can be in de novo mutations. Also, chromosomal abnormalities can cause cardiovascular diseases. To maximize the likelihood of identifying pathogenic variant, we have to choose clearly affected patients, so-called proband or index case. If we have two proband, test the potential whose onset of disease was at younger age or who lacks confounding environmental factors. But if you have no effective patients is available for testing, cardiac phenotyping of first-degree relatives may be reasonable. When we found pathogenic variant in genetic tests, and the cascade testing of family members is recommended. So, a gene panel was performed and the single pathogenic variant identified. Then, cascade testing for family members should be limited to single pathogenic variant. Gene panels vary lab to lab, so you have to be careful about which genes including. And consultation with the clinical geneticist recommended for ordering large panels or whole exome sequencing. And when to test, in adults, phenotypic features suggesting a genetic condition may be based on clinical history, physical examination, or imaging findings. Obtaining a three-generation family pedigree is a standard part of genetic evolution and can provide important clues for diagnosis. The primary reason to perform genetic testing is that the knowledge of specific gene variants may be change patient management, including the need and timing of imaging surveillance, optimal choice of medical therapy, need for surgical intervention, lifestyle recommendations, risk of pregnancy, family planning, prenatal genetic testing, and pre-implantation genetic diagnosis. This is an example of relationship between genotype, phenotype, clinical outcomes, and patient management. In patients with Marfan syndrome, a pathological variant in the gene encoding for the fibrillin-1 gene results in altered strength of the aortic connective tissue. The key phenotypic features are dilation of the aortic sinuses with loss of normal contour of the sinotubular junction, superior dislocation of the lens in the eye, and musculoskeletal involvement. There is a high risk of aortic dissection, with current guideline recommending prophylactic replacement of the aortic sinuses and ascending aorta when diameter reaches 50 mm in asymptomatic patients with Marfan syndrome. Aortopathies pose a significant healthcare burden due to excess early mortality, increasing incidence, and underdiagnosis. Understanding the underlying genetic causes, early diagnosis, timely surveillance, prophylactic repair, and family screening are keys to addressing this disease. Three groups of genes which encode proteins involved in vascular smooth muscle cell contraction and adhesion to the extracellular matrix or TGF-beta signaling pathway. Extracellular matrix group will lead abnormal, fragile extracellular matrix and can facilitate aortic dilation. Loss of function in genes encoding proteins, TGF-beta pathways probably alter tissue repair. And the contractile cytoskeleton group may alter tensegrity of the cells, which ensures homeostasis. There are some examples of different types of aortopathies, like Marfan syndrome, Loeys-Dietz syndrome, familial thoracic aortic aneurysm and dissection, vascular Ehlers-Danlos syndrome, and Turner's syndrome. And here we can see their different phenotypic features. Inherited cardiomyopathies are divided preferentially into three groups: hypertrophic, dilated, and arrhythmogenic right ventricular cardiomyopathy. Hypertrophic cardiomyopathy is the most prevalent genetic cardiac disease, affecting 1 in 500 people and generally transmitted as an autosomal dominant trait. Dilated cardiomyopathy is clinically and genetically heterogeneous disorder. Genetic factors have been suggested to be responsible for 30–50% of cases. When we come to arrhythmogenic right ventricular cardiomyopathy, it's a familial disease in at least 50% of cases, and it is most frequently transmitted in autosomal dominant manner with variable expression and penetrance. As you see in the scheme here, pathogenic genes encode genes that involve diverse biological cardiomyocyte processes. Arrhythmias in here, for example, you see in the hypertrophic cardiomyopathy, this affected tissue is sarcomere, and as dilated cardiomyopathy. But in arrhythmogenic right ventricular cardiomyopathy, we can see desmosomes are affected. Arrhythmias clinical and genetic testing can inform lifestyle, medications, ICD implantation, or left cardiac sympathetic denervation. For example, various societies about long QT syndrome have consensus about diagnosis can be based on pathogenic variant in long QT syndrome genes. In that chart, we can see the next generation sequencing sensitivity in arrhythmogenic disease. Between them, the long QT syndrome has the higher sensitivity with nearly 80%. When we come to pharmacodynamics, it aims to identify how genetic variability affects drug responsiveness and toxicity. Commonly used drugs like warfarin, clopidogrel, and simvastatin have complicated drug effects due to polymorphisms. Here, for example, in clopidogrel, one polymorphism may higher in risk of bleeding, and also in statins, in the polymorphisms in CYP3A5 gene can cause higher total cholesterol reduction. Fueled by the pharmacogenomics research, the promise of tailoring diagnostic and treatment strategies to the needs of individual patients may be within reach. Highlighting this exciting stage of rapid discovery is the development of clinical guidelines that incorporate genetic information to guide warfarin, clopidogrel, statin therapy to reduce risk of toxicity. Thank you for your attention and have a nice Congress.
Thank you, Elif, for your amazing speech. Really, we learned the state of art about this topic. And I don't have any question, but we have a question from our audience. Elif, are you here?
Yes, I'm here.
Okay. Can we perform this kind of test in cardiology area in Turkey?
Yes, for example, now I'm working in the Elazığ Fatih City Hospital, and we have 10 panels just for cardiovascular diseases. They're just special for the cardiovascular diseases. And also for the special syndromes, we can do the mutation testing. And also we can, and these panels, every 6 months, we are revised the genes included in them. And also we can do whole exome sequencing too.
Okay, thank you. And another question to Babak Sharif. Do you usually recommend to start SGLT inhibitors after metformin, or can be started independently?
Regarding the question, because the SGLT2s are not a very potent anti-diabetic treatment, if you're going to treat diabetes, you usually start with metformin. But nowadays, with the event of having better drugs like the GLP-1 receptors, these medications are more potent, and we'll see a change in the algorithm. But right now, metformin should be started, and then SGLT2 should be added to it.
Okay, thank you. We are grateful to all our speakers. Mehdi, Zoghi, do you have any addition, comment, or question?
No, thank you first off to all speakers and you for your join us.
Thank you.
Thank you very much.
I tend to believe that it was fruitful session for our audience. And I would like to conclude my speech by saying that I hope that we will do our next IYAC and Cardiovascular Academy Congress live again in Cyprus next year. See you.
Thank
Bye.
you. Bye.